Periodontitis refers to the inflammation of the supporting periodontal tissues surrounding the tooth. It is caused by specific groups of microorganisms and results in progressive destruction of the periodontal fibers and the alveolar bone. Chronic periodontitis is the most common form of periodontitis, has a slow rate of progression, and most commonly affects adults and sometimes even children and adolescents. It is associated with accumulation of plaque and calculus, but the rate of disease progression also depends on local, systemic, and environmental factors. Aggressive periodontitis, on the other hand, differs from the chronic form by occurring primarily in adolescents and young adults, causing rapid destruction of periodontium with very little or no plaque and calculus accumulation, occurring in healthy individuals with no systemic disease, and having a genetic predisposition. Aggressive periodontitis is further classified as localized aggressive periodontitis and generalized aggressive periodontitis. As the name implies, the localized form of the disease is characterized by destruction of periodontal tissues and bone loss localized only around the incisors and the first molars. Generalized aggressive periodontitis, however, has a more generalized, widespread destruction. The localized form of the disease was previously called localized juvenile periodontitis, and the generalized aggressive form encompasses what were previously called generalized juvenile periodontitis and rapidly progressive periodontitis. So localized aggressive periodontitis is very rare, and its prevalence is estimated to be less than 1%. It does not have any gender predilection and affects both males and females, usually around puberty before 20 years of age. One of the striking features of this disease is the amount of periodontal destruction with minimal to no plaque accumulation. This disease is characterized by attachment loss being restricted to the incisors and first molars. In fact, the disease does not involve any other teeth other than incisors and molars. This disease has a 2 to 3 times faster rate of bone loss compared to chronic periodontitis. Teeth mobility and migration are common signs. In fact, many patients have distolabial migration of teeth leading to a diastema formation. And of importance is the fact that patients otherwise are healthy and do not have signs or symptoms of any systemic disease. Radiographically, the disease shows vertical bone loss in the incisor and the molar area. The characteristic sign is an arc-shaped bone loss extending from the distal surface of the second premolar to the mesial surface of the second molar. There may be similar arc-shaped bone loss in the incisor regions as well. So what makes this disease restrict itself to the incisors and the first molars? Well, it's speculated that incisors and first molars are primarily involved due to the fact that they are the first permanent teeth to erupt. So organisms evade host immune responses, colonize and start inflicting damage. However, the body then elicits a robust immune response and develops a high serum antibody titer against Aggregatibacter actinomycetum comitans, thereby restricting its growth and spread. Also, other organisms simultaneously proliferate, competing and antagonizing growth of this organism. Generalized aggressive periodontitis affects individuals younger than 30 years, but could also appear in patients who are older. Similar to localized aggressive periodontitis, the periodontal destruction occurs with little or no plaque accumulation. It is characterized by interproximal attachment loss in at least 3 teeth apart from incisors and first molars. Teeth mobility and migration are common signs. And like localized aggressive periodontitis, patients do not have signs or symptoms of any systemic disease. Clinical signs are known to occur episodically, with periods of periodontal destruction and periods of quiescence. It also differs from localized aggressive periodontitis in having a poor antibody response against Aggregatibacter actinomycetum comitans. This is the reason speculated for the more generalized spread of attachment loss, unlike the localized form of the disease. In fact, many patients of generalized aggressive periodontitis are patients who have progressed from the localized aggressive periodontitis, though there are patients who develop the generalized form of the disease from the onset. Unlike the localized form, generalized aggressive periodontitis has a microbiological environment that is more diverse and also has increased quantity of organisms like Porphyromonas gingivalis, Privotella intermedia, and Fusobacterium nucleatum. Since Aggregatibacter actinomycetum commitans invades the connective tissue and the patient may have neutrophil functional defects, routine scaling and root planing would not suffice. In fact, periodontal debridement has to be complemented with antibiotics like tetracycline, amoxicillin, and minocycline. Patients are to be kept under follow-up and re-evaluated every 3 to 4 weeks. Patients with localized aggressive periodontitis have a good prognosis, but patients presenting with the generalized form of the disease and advanced bone loss usually have a bad prognosis and respond less reliably to treatment.